Hi, my name's Nick Bishop. I'm the chair of the Medical Advisory Board for the Brittle Bone Society. For those of you who don't know me, I'm the Professor of Paediatric Bone Disease at Sheffield Children's Hospital, and I've been looking after children with osteogenesis imperfecta there for the last 13 years. So the first thing I have to do is to apologise that I'm not there in person. I'm afraid I'm in the former East Germany attending a conference in Leipzig, again talking about children who've got bone disease. Overall, in Sheffield, we've treated about 500 children with OI. One of the great things that's happened in the last couple of years is that we've been able to put together a system whereby other centres in England can work together to provide a better standard of care for children with brittle bone disease. To achieve that, we've been given a lot of money by the government. We estimate, although we don't know exactly how much it is, that it's going to be around £18 million over the next 4 to 5 years. And that's going to enable us to employ more people, more doctors, more nurses, more therapists, and other support staff to try and improve the standard of care for children with osteogenesis imperfecta overall. The Brittle Bone Society made a significant contribution to that application and strongly supported our putting it forwards to the Department of Health. So for that, and for increasing the profile of osteogenesis imperfecta nationally and all of the other work that they've been doing on your behalf, I think the Brittle Bone Society deserve a big vote of thanks. I should probably tell you a bit more about the Medical Advisory Board because the Brittle Bone Society hasn't had one until this year. The Medical Advisory Board is composed of healthcare professionals, doctors, nurses and therapists, all of whom are actively engaged in the care and treatment of people with OI, and not just children but adults as well. And that's important because whilst we all recognise now that we've done a pretty good job in terms of trying to get better services for children, as exemplified by the money that we've received from the government for the 4 designated centres in England, the NCG centres. The care for older individuals and even for young adults has lagged behind in terms of its organisation and its delivery. Whilst it's relatively easy through the specialist centres to get access to highly specialised physiotherapy and occupational therapy, it isn't easy at all to get that through the adult centres, but that is beginning to improve now. So a reasonable question might be, what's the medical board going to do for me? The answer, I hope, is that we will be able to produce answers to some of the questions that you have and that you want to pose to us through the society. So, for instance, people have been asking us locally, what is the role of bisphosphonates in causing fracture non-union? I'm not saying that the Medical Advisory Board is going to come up with an instant answer to that, but it will be in a position to draw together the evidence and provide a considered answer, taking into account the views not just of paediatricians but also adult physicians, orthopaedic surgeons, spine surgeons and so on, so that we will, I hope, be able to give you more and better information about the things that really bother you rather than the things that perhaps just bother us. The Medical Advisory Board is also there to support the Brittle Bone Society in providing general information to members. For instance, around fact sheets like the genetics of OI, the care of a baby with OI, where you can access services, and so on. So the Medical Advisory Board will have a wide-ranging role. It'll meet on a regular basis twice a year, and we hope that it will be of benefit to the society. The money that we've received from the Department of Health to create 4 designated centres for the treatment of children with complex, severe or unusual, what we call atypical osteogenesis imperfecta, is very welcome. But we're not just treating children from England. Under the terms of the NCG agreement, we also treat children from overseas, particularly from Ireland, and they count as patients within our service. A lot of those children are also severely affected, and it was great earlier this year to go over to Ireland with the support of the Brittle Bone Society to meet up with the Irish paediatricians who are looking after those children and to see how they're getting on, because, believe me, their services are a good 10 to 15 years behind where we are currently. So we're keen to give them help and support and hope that in the next 5 to 10 years they'll be able to stand on their own feet as well. The designated centres are in London at Great Ormond Street, in Birmingham and Bristol and Sheffield at the children's hospitals there. In time, we hope that each of the centres will offer pretty much exactly the same level of service. Each of the centres will also be providing outreach clinics and going to other places that do provide care for children with OI, but perhaps don't have quite the same access, particularly to specialised therapists and nurses. Because giving the bisphosphonates to children with OI is really the easy bit. The difficult bit is what the therapists and the nurses do, in my view. The hands-on work with parents and with children, making sure that the everyday things that really matter to individual families are sorted out for that individual. So we're providing individual solutions for those individual problems. While I'm talking about therapists, I should mention the Paediatric Osteogenesis Imperfecta National Team, otherwise known as POINT. This is the group of therapists and nurses who meet regularly to discuss the paediatric side of brittle bone disease in therapy terms, so occupational therapy, physiotherapy, and more recently now psychology as well. These folk, as well as the nurses, get together on a regular basis about once every 6 months. And again, they try to draw together their expertise to create guidance which they can use either themselves or to give to others, to develop agreed ways of dealing with specific problems and just generally to try and improve the care and the service that's given to children and their families with OI. In terms of new treatments for OI, we've been hearing about bisphosphonates now for quite some time. As you all probably know, bisphosphonates work by slowing down the rate at which bone is destroyed, whilst allowing bone still to be built up, at least when you're still growing. In adults, it is much more a question of bisphosphonates slow down the rate of bone destruction primarily. It's probably for that reason that we see that bisphosphonates are generally more successful in reducing fracture rates and removing bone pain in children as opposed to adults. There are new treatments on the horizon. There is a new treatment that completely stops the breakdown of bone, called denosumab, which has been approved for the treatment of osteoporosis in postmenopausal women. We don't know if this is likely to be an effective treatment for osteogenesis imperfecta or not. It's a bit like flicking a light switch. It's all or nothing with denosumab. It means that we can't really control it in quite the same way that we can with bisphosphonates. To my knowledge, there aren't any studies ongoing with this drug, and as far as I'm aware, there are none planned at the moment. There are other drugs that are being talked about which could help to build bone up. In adults again with postmenopausal osteoporosis, parathyroid hormone has been used to rapidly and significantly increase bone mass. And I know that some adults with osteogenesis imperfecta in some centres have received PTH as well. PTH, or parathyroid hormone, sometimes called teriparatide, has not been used very much in children at all. And there's a reason for that. When they were doing the preclinical studies, they found that giving PTH to rats caused them to develop bone tumours. And so there was a warning put on the label not to be used in the growing skeleton. For that reason, the use of PTH has been something that we've all shied away from. It might be that in time we understand it well enough to use it appropriately But at the present, we are stuck with the bisphosphonates. And I would suggest to you that they have done an awful lot of good. Compared to where we were 10 to 15 years ago, I believe that the quality of life for most children who've received bisphosphonates in their families has improved significantly. I've no doubt that we do have significant issues that we need to address in terms of their use still. But I think that they are a good drug, and we are going to need to continue to use them for the foreseeable future. What's the evidence that bisphosphonates are good drugs? We've recently completed a multinational, multi-centre study using risedronate, which is one of the more recently developed bisphosphonates. When we gave that to children, we saw a 50% reduction in fracture rate compared to children who received a placebo, a blank pill with no activity. This is the first time that any study of OI in children has robustly demonstrated a reduction in fracture incidence. We're hoping to see it published in the next few months in one of the leading medical journals. But it does underline the fact that we've come a long way in the last 10 to 15 years, and that we can say that we think this sort of treatment is effective. So, what does the future hold? I think for the Society and for the Medical Advisory Board, our priority in the next 5 years or so is going to be to try and get adult services up to the level that's currently enjoyed by paediatric services. I don't think that's going to be an easy task. I think, in fact, it will be very difficult, particularly in the current economic climate, but it's an important thing to do and a very worthwhile one. It may be that there are new treatments coming along that will make our lives easier, but at the same time I expect that there are a lot of adults out there who will continue to need access to specialised nursing and therapy services, and that's not something your average physician is going to be able to supply. So it only remains now for me to say to you all, I hope you have a really good conference, and for those children in the audience, please stay off the roller coaster. Thank you very much. Bye.